Welcome to the Kelly West Award for Outstanding Achievement in Epidemiology lecture. My name is Sagar Dagani, and I'm a physician researcher at Mayo Clinic in Rochester. I also serve as chair of the ADA Epidemiology Subcommittee. It's my distinct pleasure to chair this session that's designed to recognize a distinguished epidemiologist. The Kelly West Award is in memory of Dr. Kelly West, who is widely recognized as the father of diabetes epidemiology. Dr. Kelly West, in the 70s and 80s, studied the natural history and mechanism of diabetes at a time when much was not known. In 1986, 40 years ago, the ADA established the Kelly West Award to recognize leaders who have made a substantial contribution to our understanding of diabetes epidemiology. This year's recipient, Dr. Muhammad Ali, epitomizes the excellence, impact, and brilliance inspired by Dr. West. Dr. Ali is the William H. Fagey Distinguished Professor, co-director of the Emory Global Diabetes Research Center, and a primary care physician at Emory University. He was a Rhodes Scholar from South Africa and studied at the University of Oxford. Not content with that level of education, he then completed his MBA and Family Medicine Board certification at Emory University. Over the last 2 decades, he has studies and trials on preventing diabetes and its complications. He's contributed to initiatives and programs by the US CDC, the World Bank, the World Health Organization, and the International Diabetes Federation. He is also a member of the National Academy of Medicine and has published over 170 papers. When I was communicating with Dr. Ali in the last few weeks, so I referred to him as Dr. Ali in my initial email, and he immediately wrote back and said, "Please refer to me as Mohammed or Mo." And despite his many accomplishments, he remains humble. He's widely liked and respected, which in today's world is very difficult to be both. He has accomplished more than most of us would ever in a lifetime. And for his brilliance, impact, and humility, he's highly deserving of this award. I hope when all of you have a chance at the end of this lecture, you have a chance to congratulate him, as well as his wonderful family, his wife, his kids, and parents are all here in the front rows. I hope you'd have a chance to talk to them and just see his roots and what inspires him to do greatness across the world. So he's most deserving of the Kelly West Award. And with that, please join me in welcoming Mo Ali.
Wow, that was an incredibly generous introduction. Thank you, Sagar. And thank you everybody here for showing up. There are obviously other things you could be doing with your time, like watching Roland Garros or the Monaco Grand Prix. So I appreciate you being here to listen to this talk. Thank you to the American Diabetes Association, and also thank you to the 3 kind souls who nominated me for this award. I think sometimes that they had more faith in me than I have in myself sometimes. And I really appreciate that. It's a tremendous honor to be here. These are my disclosures. None of these are relevant to this talk today. And so as I get going, I wanted to just start, if you'll indulge me, with the idea that, awards are given to individuals, but really are a reflection of the work of many. And us scientists, we only get to feel like a celebrity once in a while. And when you get it, I'm going to take this as my Oscars moment and thank everybody I can. And of course, I'm going to forget people. So if you're out there and I've worked with you, I'm already indebted to you, and I apologize for missing it, and I apologize for not including it. There's sometimes just very little that this memory and this brain can hold. So I want to start with Venkat Narayan and Ed Gregg, who have shaped my career pretty much. And I would say that they taught me about the rigors of science and selflessness in research. I owe a huge debt of gratitude to my friends, Drs. Nikhil Tandon, Dr. Prabhakaran, and Dr. Mohan, who's here in the audience. all of whom 18 years ago, when I was just a postdoc, gave me a seat at the table and really allowed me to develop and design studies with them. And a really important group of people, Dr. Ampirez, Dr. Mangione, and Dr. Del Rio, who helped me in my adventures back to clinical medicine, which, when you combine it with epidemiology, is just that wonderful ability to be able to look and see the forest from the trees, but then also spend time and understand the challenges that every single tree faces themselves. There's this amazing generation of people I get to work with who are the young and future stars that are going to lead this field, as far as I'm concerned. I am so grateful to all of them that they've entrusted us with their careers. Working with them has been an absolute delight. So many of them inspire us with new ideas, and I'm pretty confident a number of these people are going to be your and my boss one day, so be kind to them. We have a tremendous group at the Emory Global Diabetes Research Center who are our administrative staff, led by my friend and colleague, Mark Hutchison, who's somewhere in the audience back there trying to hide. Mark's team is just tremendous, and they really do a wonderful job at keeping us going in all the research we do. I've been very fortunate that they are here today with us to celebrate this award, but my parents have been an amazing pair of people who moved 4 different countries in the first 25 years of my life and have really taught me a lot about perspective and optimism. People often ask where I get it. It's the pair of those 2 people over there who have given me a lot of optimism in every opportunity I've ever wanted or tried for. To my dear wife, Nadia, who's sitting in the front row here, thank you for everything you do. You have made our house a home. You've carried an invisible load that we don't often talk about, but I really appreciate it. And you sacrificed personally and professionally for me and for us, and I appreciate that. And you've tolerated me for 17 years, but the next 45 minutes are going to be hard to tolerate because you're going to have to do them uninterrupted. To our sons, Faiz and Abrar, you are actually the biggest award that Mom and I will ever get, and we look forward to the really cool things you'll do for humanity in the future. I also want to take a moment, if I may, to just talk about where we are in the world today. And I wanted to share this quote, which is on the dome inside the National Academy of Science. And it says, "To science, pilot of industry, conqueror of disease, multiplier of the harvest, explorer of the universe, revealer of nature's laws, and eternal guide to truth." And the reason I put this up here is that I think it's a difficult time for science in America, because I think there are pressures coming from the administration and the government on science and scientific findings, both to suppress them and to put pressure on others to suppress them. And I have to admit being quite disappointed that the American Diabetes Association stifled a number of our colleagues exercising their free speech. On Friday. And you know, one of those people, Steve Kahn, he and I share this history of having been in post-apartheid South Africa, which to me gives us a lesson for today, which is that you don't need to be on either side of this argument. You actually just need to figure out truth and reconciliation, which is what Nelson Mandela taught us. After 27 years in prison, he had the guts to come out and not actually be bitter about it or imprison anybody. He put out a hand of compromise and truth and reconciliation. And I do feel that in this moment, between the group that was ousted from the ADA meeting and the American Diabetes Association, I think some form of compromise and some form of apology could help move things a lot better. So, on to the talk. My talk is inspired by this idea that research is not done in isolation. It's done with the sole purpose of climbing the stairway to heaven, if you will. That's what Anne Albright used to call it when I started my career. She is the previous division director of diabetes at the CDC. And there's this idea that, epidemiology and research and data are supposed to inform practice and policy change. And there was this idea that you sort of climb the ladder to the top so that we can get good population health outcomes. Now, just to mention, I'm going to use this as the framing for my talk today, and I am going to focus on type 2 diabetes, not so much type 1, and also I'm going to focus on adults. Not to say children are not important, but I'm hoping you will see over the course of this talk that everything I say is actually going to apply both to kiddos and to type 1s. So here's how I'd like to organize myself. First, I want to talk to you about the era of averages and the impacts they've had on one-size-fits-all approaches. I want to talk a little bit about the outset of precision diabetes and really end with this idea of what are the epidemiological and translation challenges of actually realizing precision diabetes globally. So let's start with the era of averages and meta-analyses and our goals in my career, at least the first part of it, in trying to find one-size-fits-all strategies. And we've really used this approach, right, where we've seen in trials and in cohort studies and other things, the averages that we compare lead us into guidelines, which lead us into treatment and hopefully practice change, and hopefully some form of population health change. This is well evidenced by the idea of the Diabetes Prevention Program study, now 25 years old, where people with prediabetes were definitely at high risk. This is the placebo group you're seeing here, and you're seeing the cumulative incidence of diabetes on the y-axis and the years since randomization. This group who had impaired glucose tolerance and quite high fasting glucoses developed diabetes at a fairly high rate every year. The group that got intensive lifestyle modification, which was structured counseling, 150 minutes of physical activity a week, reduce your calories, lose 5 to 7% of your weight, did have a marked reduction in diabetes incidence, a 58% relative risk reduction between those groups, a number needed to treat of 7, so highly impactful study. And in between, there was this group that got metformin, who had about half the benefit. And so as we thought about these average effects, our group in particular was quite active in thinking about what does this mean for the whole population. And Carla Galavitz and others on this slide, you'll see, had done a tremendous job in meta-analyzing and pooling a lot of these data. We looked at, for example, all the lifestyle trials, and then these are the ones I'm just showing you that had long-term follow-up. So just in the early years where we had normal follow-up, you'll see here the active intervention years, we had an average 45% benefit in those different trials. And then Carla and company looked at the follow-up years beyond that, and you'll see that 5 to 10 years later, there continued to be a 28% benefit of lifestyle interventions on preventing diabetes. When we compared this to medications, where you had the medication for the active period, but then you had a washout period and follow-up, there was absolutely no difference. Medications worked while you took them, and the moment you stopped, the incidence of diabetes went back to being the same. We then looked at what this means for translation studies, and Carla did an amazing meta-analysis of 63 different countries around the world, about 17,000 people in it, mean age of 50, 30% men, mostly women in those trials. And you'll notice that a number of them worked. They had modest weight loss, but actual impacts on diabetes incidence. And this was actually quite remarkable. The idea that you could get a 30% relative risk reduction in diabetes in translating these studies was quite remarkable. And one good example of that was led by Mary Beth Weber and Dr. Prabhakaran and Dr. Mohan, which is called the India Work Study, where they went out to 11 different big employers, Air India, Tata Steel, you name it, these sort of big household names in India, and they recruited people in very different jobs. You'll see sedentary jobs, active jobs, hard hat jobs, and they managed to get them to do Zumba. They screened 6,500 people, half of which were at high risk for diabetes. And in the 2,000 people enrolled in this study, they had extremely low loss to follow-up and a 25% reduction where people got to normal glycemia in that group. What about diabetes care? We've been using average effects for diabetes care for some time, using observational studies, the randomized control trials that we all know and cite regularly, including the STENO2 study, which really helped us think about the comprehensive nature about the way you treat diabetes. And then the many meta-analyses that follow that guide our practice and tell us about blood pressure lowering and cholesterol lowering. And to translate that into practice, there were additionally quality improvement studies, which again were beautifully meta-analyzed by these two groups about 15 years ago, where they essentially showed that if you take patient-focused, clinician-focused, or care system-focused quality improvement approaches, you could get benefits for diabetes. And in particular, any of them worked and would get you about a 0.4 percentage point reduction in A1C, would get you better screening, and would get you a modest impact on blood pressure. Critically, they made the point that when you use multiple of these strategies together, again, pool things together, average them out, don't worry about the details, you get even bigger A1C impacts. So a number of us, Nikhil Tandon, Dr. Mohan, Kavita Singh, and others, we actually ran 2 different randomized controlled trials in India and Pakistan to basically test whether these quality improvement approaches work. And again, thinking that we needed the multi-component piece, we went ahead and combined our interventions where we used non-nurse care navigators to empower our patients, which is way at the top there. We used clinical decision support prompts in computers to help our clinicians make sure they were achieving the types of things they needed to do in terms of delivering statins, up-titrating medications. And we used audit and feedback to make sure that our care coordinators were focusing on the patients that really needed the most amount of help. And these were pragmatic randomized controlled trials. So clinicians that saw our active intervention group patients also saw our control group patients. So you will see benefits in both arms here when you see the data. And I'm just showing you the data from the CARS trial, which is 1,200 participants, 10 sites in India and Pakistan, where these people at start had mean A1Cs of 10. So they were really poorly controlled. And you'll see here huge benefits. We continued the active intervention for 2.5 years. And the intervention arm, as you can see, had a bigger benefit over time and managed to maintain that over the 2.5 years of follow-up. We saw similarly blood pressure benefits as well as LDL cholesterol lowering benefits. And we managed to follow them up for 7 years, showing that actually a combined micro and macrovascular outcome was far better in the intervention group than in the control group, giving us a 28% relative risk reduction, a number needed to treat of 14 to prevent 1 complication of diabetes. Really awesome after this is the hard work that Shivani Patel and Nikhil Tandon did in engaging the government of India and local governments in the state of Punjab to take that intervention I just showed you and try to do it in this type of rural facility in Punjab, where it's really hard, as you can imagine, to translate what happened in a well-controlled clinical trial into real practice. And so kudos to Shivani and company. They managed to show that amongst those with diabetes, over a short intervention period, they increased awareness in communities of diabetes and diabetes diagnoses by 13 percentage points, improved treatment by 15 percentage points, and control by 4 percentage points. This led to, again, a more average approach, which is to say that Ed Gregg accumulated a number of us to really start and think, could we use metrics and targets for countries to really push the quality agenda for diabetes? And what we decided was that we should do this, and Jonathan Shaw and Jen Manny and others in the audience were part of that committee. And we settled on this idea that we need to target at least 80% of people with diabetes getting diagnosed around the world. Amongst those that are diagnosed, we will try to push countries to achieve actually quite modest targets, right? A1Cs under 8, blood pressures under 140/90, and at least 60% of those aged 40 and above receiving a statin. We also made the very lofty but important target of 100% of people with type 1 diabetes having access to insulin and blood glucose self-monitoring. So, the average one-size-fits-all approaches, in a nutshell, did they actually have population impacts? And so here are some of the data that we have developed over time, and we've used this approach of thinking about if you have a target population like so, we need to think about not only the end user, but before them, the clinics and clinicians, are they adopting the thing you wanted them to? So the guideline, does it get used? And you can measure that quite often. And then second, out of that group, are the end users actually adopting what you want them to in the guideline? And third, is that then giving you the health outcome you're hoping for? And this is really telling us a lot about how we take epidemiologic and guideline-based data and translate it. Does it actually give us the impacts we want? And subtly in there, you can tell that for those last three bars, policy and access play a huge part, not just behavior change and not just how people think or adhere with what we tell them to do. And this is well exhibited in some of the data we have on diabetes prevention here in the United States. I show you those terrific data from DPP. Well, did that translate into anything? So a few years ago, colleagues at the CDC and I looked at this and said, okay, of the 70 million people back then with prediabetes, 15 million actually know it, and that's this bar way at the left you see there. Of that 15 million, the height of every bar after that is, did they get told to do any one of those things? So anything from glucose testing, physical activity advice, dietary advice, weight loss program referral, or DPP referral. And you can see a huge drop over time, especially in referrals to programs. And then the portion that is colored light green is out of those that got referred, those are the ones that actually went. So for every one of these, there's at least a 25 to 30% drop-off in those who actually go. We also looked at the group who didn't know they yet had high risk for diabetes. They just are walking around not knowing that they have high or mid-elevated intermediate hyperglycemia levels, and you can see bigger drops for them. The take-home story is that at that time, out of 70 million people with prediabetes in the country, only 1 million had been referred to any program, and probably only half of them had actually gone and enrolled in that program. The most recent data I have are from 2023 since then, which is that we have 2,000 NDPP programs around the country, and 3% of people with prediabetes have ever engaged. So massive drop-offs from the real aspiration that we have. And what that's led to is continued growth in diabetes across the country. These are county level data from 2004 all the way to 2024. We now have 40 million people with diabetes nationally. That is double what it was back in 2004, which was just a couple of years after the DPP came out. So we haven't done a great job of translating or realizing the population benefits of the average approach. I mentioned Jen Manny-Geller. She did this work looking at low middle income countries, taking data from 44 different countries, about 150,000 people, 60,000 of which were high risk for diabetes. And you'll notice here that of people reporting getting any physical activity counseling, any weight loss management counseling, any dietary counseling, a third of them got nothing. And that's just the average. When you look across the different low, middle, and upper middle income countries, you'll notice that, especially in low income settings, it's 2/3 of people that absolutely got no guidance on diabetes prevention. And you'll not be surprised then to see that diabetes has grown fourfold over the last 30 to 40 years. And it's low middle income countries, particularly in Asia and South Asia, East Asia, where the biggest increases have happened. In terms of diabetes care, how have we done? So we showed some years ago small improvements over time in the top left corner of glycemic control of the population with diabetes in the United States. small benefits of blood pressure, big jumps in lipid control, and then all risk factors controlled, we're getting close to 25%. And Michael Fang and Liz Selvin followed that study up, looking at the years after that, where essentially we've plateaued and have shown no improvement in the past decade. This is mirrored by the fact that Ed Gregg's terrific work some years ago showed that we had benefits in diabetes complications in the country in terms of heart failure, hyperglycemia, stroke, all the really scary, horrible things we want to prevent in people with diabetes were all going down. Sadly, since then, we've seen an uptick in almost every single complication nationally. So those are the sad data about the United States. What about elsewhere? My colleagues Jitin Varghese and Anjana Mohan used two different data sets to look at the continuum of care in India for diabetes. I'm just showing you Jitin's data from NFHS, but Anjana did the same thing with the ICMR INDIABS data and showed, again, big drops in the group with diabetes going down to treatment and control. Jen Manny did the same analysis in 28 different low and middle income countries, and you'll see here big drops in diagnoses. So very few people in low middle income countries are diagnosed, and similarly very few are treated. So again, the averages tend to hide the fact that in high income countries we have problems with control. In low and middle income countries we tend to have bigger issues with finding people and initiating treatment to begin with. What that has led to is these data from 100 different countries that David Flood led, just recently published, 100 different countries with data up to 2023, showing that on average, in terms of trying to achieve the 80, 80, 80, 60 WHO targets I told you about briefly a minute ago, we're getting part of the way there. 63% in glycemic control, 63% in diagnoses, and then amongst those diagnosed, 70% blood pressure control. And look at that humongous gap in statin use. It's just enormous. On average, the number of countries actually meeting our 80% targets was 8 for diagnosis, 8 for glycemic control, 15 for blood pressure control, and 7 for statin use. So we have massive gaps the world over. So as you can see from these data, the population effects I've shown you were really rather modest and suboptimal. And also, it's even though we had average effects, it was quite challenging to scale up what we thought would work from the trials into real life. The other piece I want to share with you now is this idea that the averages hide the heterogeneity of diabetes itself. And our average probabilistic estimates are actually sometimes unhelpful even when we don't think of the population data. When we think about the individual patient interaction, I bet all of you have heard this story at least once in a clinic, which is to say a person comes in and says, "Doc, my dad smoked 2 packs of cigarettes a day and lived to 98. Why do I have to worry about not smoking?" And so it's the idea that the probabilistic average estimate doesn't work for individuals, and I'm going to try to convince you of that just now. So there's variation in biology, as you can imagine, and a lot of these data come from about a decade ago, where my colleague Lisa Steinmetz and Venkat Narayan and Dr. Mohan set about looking at a tale of 2 Indians, trying to argue that the type 1, type 2 dichotomy was not enough for the way we were thinking about diabetes. And they looked at these 2 groups of people, the Pima Indians in Arizona and Asian Indians in Chennai, India. And you can see that both of them by age 55 had a horrendously high prevalence of diabetes. 50% of them had diabetes by age 55, but that they looked very different. The Pima Indians were highly obese, mean BMI of 33, whereas the Asian Indians were relatively lean. The glucose profile was very much a higher 2-hour glucose in the Pimas and much more of a higher fasting glucose in the Chennai Asian Indians. And we saw a big difference between the Pimas, who were much more insulin resistant, and the Asian Indians, who had more of a secretory defect. And so about 11 years ago in his Kelly West Award lecture, Dr. Narayan pitched this idea that the metabolic load group, the Pima Indians, really had difficulties with insulin action and insulin resistance, whereas maybe there's a different group, a type 2B, who actually had an insulin secretory problem, being inspired by that Asian Indian group that we analyzed. Since then, as many of you know, there has been a lot of movement in this idea that there are not just one type of type 2 diabetes. Emma Alquist and others did a machine learning exercise with a lot of their data from Sweden, and they proposed this idea that indeed there is an insulin deficient group, or the SID group, severe insulin deficient diabetes, who make up about 18% of the group in their analysis, who generally are people who are young, low BMI, very high glucoses, and have a beta cell problem to begin with. There's another group that are the severe insulin resistant diabetes, who make up about 15% of the population, and essentially have high BMIs but really terrible insulin resistance. And then there are two other groups, a mild obesity group, who are high BMI. As soon as the weight gains, their glucoses shoot up. As soon as the weight goes away, their glucoses go down. And they don't have any other major metabolic derangements. And then about 40% of the population are this group of what we call mild age-related diabetes, where advanced age, relatively lean, don't have a whole lot of metabolic abnormalities. And when we see them in clinic, they have A1Cs of 6.6 to 7.9, and they don't really move much after that. Importantly, knowing that these subtypes require data that needed fasting insulins and other measures, Zhangyu Li and Jitin Varghese basically took these same Alquist phenotypes, subtypes, which were replicated in about 60 different studies, and used cohort data in the United States to crosswalk them into routine clinical features that we could then use as a computable phenotype to identify them in EPIC Cosmos. And when they ran the analysis, they found this distribution, which was actually very similar to what you saw on the slide before. 40% mild age-related diabetes, 20-odd% severe insulin-deficient diabetes, 24% mild obesity, and another group that we just couldn't identify as being SIRD, but we couldn't identify them and put them in any other bucket. Importantly, what they then did was they looked to see, do these actually lead to different complication profiles? And it was markedly interesting data, where you'll see the blue group, which is the severe insulin-deficient diabetes, had a much higher risk of all of these different complications, from retinopathy, nephropathy on the top rows, to severe atherosclerotic cardiovascular disease and heart failure on the bottom rows. Really interesting data since then, and just published a couple of months ago. Ram Jagannathan took our data from the CARS cohort in India that we've been following up since 2010, and there were 14,000 participants in this analysis. Ram went ahead and said, let's understand the distribution of these subtypes. And using machine learning, the subtypes were slightly different. You'll notice here 20% diabetes prevalence in this group. Of them, a quarter of them severe insulin deficient, another half of them mild insulin deficient, and then only a small portion left that are severe insulin resistant diabetes. No MARD, no MOD in this group. And then we also looked at the prediabetes group, which made up 35% of the cohort. At baseline, 66% of them had insulin deficient prediabetes phenotypes, and only a third had insulin resistant phenotypes. Ram then looked at the data and followed them up for 10.5 years, about 1,000 deaths, 400 of which were cardiovascular disease. And look at these remarkable data. The SID group had 3.5 times the hazards of mortality than any other group, and most of it was cardiovascular, as you can see, with that group losing 18 years of excess life lost. Now you'll notice some of the other groups also had a lot of life years lost, but the prediabetes group did not so much. So the big take-homes that Ram leaves us with are, number one, insulin deficiency seems to be the predominant subtype here, accounting for over 3/4 of the people in this analysis, and conferred such a huge mortality burden and years of life lost. So that's the biological argument. I would like to propose the idea that there's also psychological variation in how we think about diabetes prevention and diabetes care uptake and actual impacts in the population. And a lot of that is based on this cartoon that I've literally been using for 18 years in every talk I give. And it really shows the idea of present bias, right? The idea that we guide our patients to do things that they don't always think is meaningful to them or gives them quick and immediate rewards. So there are a number of issues, obviously, in terms of the way the end user thinks about it and what other challenges they have, how capable they are to do any of the things that we need them to do, and how literate they are to do any of the things we need them to do. And so there's this idea of what we call time preferences and variation in time preferences. The idea that some parts of the population are present focused, they want quick rewards now, and there are others who are happy to do something where it'll have later benefits. And you can imagine this has massive impacts on how we think about diabetes, because diabetes prevention and management are both extremely behaviorally demanding. And they require people to take daily actions where the benefits might be felt years later, which they might not be convinced of either. And that what this means is that people who are very present focused might skip medications. They might defer eating healthier. They might defer appointments. And similarly, there's a group that have risk preference differences. So for example, the idea that there's a group of people out there who are risk averse and just want to be doing what they're doing right now, while there are others who might actually take on different risks. And this obviously has impacts on how they think about new therapies or how they think about taking therapies at all. We actually looked at these data again in our CARS cohort, trying to understand whether behavior and risk time preferences differ or not. And I'm very thankful to Nikhil Sudarshanan, who ran these data, these preliminary data recently, where when we looked at it, if you look at this paradigm, this idea of the risk preferences on your y-axis and the time preferences on your x-axis, you'll notice that there's no one big group that predominates. The population of people, at least in India, South and North India, in this analysis, seem to differ quite a lot, where there are not obvious pockets of people we can figure out, oh, everybody's going to be present focused, so we should work on rewards. What it means is that there's huge heterogeneity out there, and we need to find different ways of leveraging that to get better uptake. Some of that might also be shown or help us explain these next data, again from the CARS cohort, where Felix Teufel did this beautiful analysis, again showing us where averages fall short. Basically, what Felix did was he looked at the baseline of our CARS cohort, people with diabetes. And of these 2,000 people, you'll see here at the top, about a third of them were undiagnosed, 10% of them were diagnosed and untreated. About a quarter of them were diagnosed, treated, but uncontrolled. And the blue group is the sweet spot. We think they're awesome, right? They're doing everything we want them to do. 30% of them diagnosed, treated, and controlled. Trifecta. Amazing. What Felix showed is that when you follow them up over 8 to 10 years, the data look like this. And so you see movement. You see positive movement. You see undiagnosis going down. Yay, that's a big win. You see diagnosed and untreated staying about the same. Okay, not great. You see the diagnosed, treated, and uncontrolled grew a tremendous amount, almost doubled. And you saw a small improvement in those that were diagnosed, treated, and controlled. But when you look under the hood of what happened in those years before, using a Sankey diagram, then the story really emerges. So yes, we had a whole bunch of people who got diagnosed. Almost 2/3 of them went into treatment, but 1/3 of that group went into treatment and uncontrolled. 1/3 of that group went down and got controlled. Here's where the fun begins. The group that was treated but uncontrolled just stayed that way. But really, this group that we thought were the best, that we love, and we think they're going to be stable over time, it turns out that about 80% of them change. 40% of them actually change. And pretty much the biggest group of those loses control over time, And in fact, 10% of them actually even just stop treatment over time. So this really shows you there's not only variation in the way people think about adopting, but there's a difference in once they've adopted, over time, they might de-adopt the things we told them to do or de-implement. And so we need to actively think about what this means for us in how we translate. It's not just the patient, which I already have complained about. It's actually also us. It's also the clinicians and how they think about accountability, how they think about inertia and being up to date with the evidence. But then it's also about care systems and fragmentation, which we have major problems with here in this country especially. It's well beyond the scope of this talk, but there are so many differences in access. Some of them are unconscionable in this country and such huge variation. And over time, what that leads to is big differences in outcomes. And I'm thankful to my friends like Carol and Tanaz and others who work in the NextD and Triad groups, where a lot of this science can really move forward. I would encourage and hope that the science can also be thoughtful about the huge variation and not just the averages as they go forward. So, hopefully I've made the point that the averages don't work that well. Now is the hard part of trying to convince you that we might be able to embark on an agenda that helps us figure out how to do precision diabetes. And Dr. Kelly West said it, every one of us has written it in a paper. We need more research. Keeps us all employed. And so I would argue that the research we need in the next decade, maybe quarter of a century, needs to be thoughtful about this biological heterogeneity and precision diabetes treatments. It also needs to be thoughtful about the psychology of our end users and how they can access anything. So the combination of optimizing demand and precision policy, I think, are new waves that we need to think about. So when it comes to epidemiology and surveillance, I would argue that we need to rethink our definitions of diabetes, and we need to rethink what that means in terms of how we do the epidemiology and surveillance of the future, i.e., do we have the variables and the data to do that work? Some of this is a really nice teaser from Jitin Varghese and Jiali Guo, who basically helped us using retrospective data from 4 different cohorts in the United States, about 10,000 people in those cohorts. And what they did is they identified where diabetes emerged with a glucose measure and looked back. And what they found is totally fascinating. This idea that weight in the years prior to the diagnosis, so if I can orient you, where you see your marker right now is where the person was diagnosed, and we are going backwards from that time. You'll notice that the 5 years prior to diabetes onset were where the biggest changes happened, and weight didn't matter as much to distinguish any of these 3 groups, the mixed, the SID, and the SIRD. There's almost no difference. They all gain a little bit of weight. The only big difference is those that don't gain weight don't have diabetes at all and or get mild age-related diabetes. The other interesting point they made is that insulin resistance seems to be an interesting feature, again, of all 3 of those subtypes, not as much the no diabetes and the MARD group, but insulin resistance does go up for all the other groups. The big kicker and the big difference seems to be the A1C drives up, but it's really driven by this beta cell drop off a cliff that happens in the 5 years prior to diagnosis. And so here's what I would like to pitch, is that we've been using glucose for the longest time, but glucose is so far downstream of any of these changes that we really should think a little bit more upstream. And I'm not one of these people who's part of these consortia, but I really think that the Lancet commissions that are ongoing around precision diabetes, the defined T2D group, I'm hoping that we will see something where we can actually become a little bit more like cancer, where we actually look at the mechanisms that are driving diabetes, not the endpoint late downstream glucose change. And so maybe C-peptide is one of these, maybe fasting insulin is one of these, but we need definitely to rethink the way we think about diabetes to start earlier. The second piece, as you can imagine, is we need to have those data points in our surveys and in our data sources. And the variables are the least of our problems, because nowadays our national surveys that I built the first half of my career on have response rates that are lower than 25% for NHANES, and BRFSS was at recent count at 43%. So do we really want to believe these surveys where almost 3/4 of people aren't even responding? I don't think any level of statistical gymnastics can get us out of that. The second area, obviously, I think we need to work on is this idea of precision trials versus sort of general approaches. And in some of the data that Satish Thiru did, in terms of the analyses that he did, combining individual level data, he did a better job than we did in our meta-analyses. We did all these study level pooled analyses. He used individual level data, making the argument that if you actually look and give these groups DPP interventions, the conventional approaches seem to work differently if you have isolated impaired fasting glucose, glucose tolerance, or combined. You'll see both the groups that have combined or impaired glucose tolerance work beautifully. It's the IFG group where it didn't work at all. Similarly, I would make the argument to you that in our trials, which were very effective, I showed you the quality improvement trials where our intervention arm had twice the benefit than the control arm. What I'm hoping you notice as a good epidemiologist is that the absolutes are very small. 20% of the intervention group improved compared to 10, which means that 80% of those people did not benefit. And so we need to do a deeper dive of trying to understand how can we do better. We know that group and that group, the intervention group is supposed to succeed and the control group is supposed to fail. But what about the other two? What about people in the control group that did well, that made up that 10% that did well? And what about the intervention group that failed, the 80% that were supposed to succeed? And so really, we are currently doing these secondary analyses, and we're discovering that it looks like vision, neuropathy, and age were the biggest predictors of failure to succeed in the intervention group. So it may be that those groups need even more support than we are currently giving them in our one-size-fits-all quality improvement approaches. So it leads us to this idea of the precision diabetes framework. And Paul Franks and others have made this argument that we should be doing more in this space. I would argue that the data are not ready and that we need more trials. One could think about this from the perspective of taking a population of people, dividing them into these subtypes, and giving them a subtype-specific treatment, and then seeing what's happened. Jitin and others have taught me recently that actually the data that's out there for these trials are not actually that impressive. It seems like in this study, for example, 240 people randomized, half of them SID, half of them SIRD. 50 of them, 20%, didn't even make it to the finish. And we saw no real separation between the drug classes. And all of them were getting either SGLT2s or GLP-1s. Now, it might be that this no separation is because the drugs that we used were overpowering. Or one could argue potentially that maybe neither of these treatments is the precise pathophysiological treatment for these subtypes. It's possible that SID, the severe insulin deficient group, might benefit from a islet boost or potentially regeneration or other ways that we can think about this agenda. So there's a counter proposal from John Dennis and others at Exeter. They make the idea that subtypes themselves are also still too reductionist, because it might be that some people don't fit into one of those four, or some people might fit into multiple of those four. And so John Dennis and team are pitching this idea that potentially you can model out personalized N of 1 treatments for everybody based on routine biomarkers. And the way they've done it is they've used observational data with these routine measures and then gone ahead and built models that they validated in clinical trials. And what they seem to be showing is a modest benefit, about 0.5 percentage points of A1C benefit on a second-line diabetes oral medication only, 38% relative risk reduction in people needing a third medication, and about a 14 to 30% lower risk of microvascular CKD and heart failure complications. And they are driving this agenda, and they've even put out an interesting clinical calculator that I'm told is for research purposes only. Please do not try this in your clinic. So you can see that, we've gotten to the point where it was hard enough using our average effects with RCTs, But there is going to be this question of when we add more and more data, we're probably going to need artificial intelligence. We're probably going to need these behavioral phenotyping data, the omics data, all mixed in there. And you can imagine the amount of complexity we're going to need. It's going to be highly data intensive, require systems where the variables exist for us, and require huge compute. And then, if that wasn't enough, we need human adoption, which, as you know, in today's world is challenging because we are all definitely a little bit skeptical about AI. So as we think about implementing this in practice, AI kind of feels like the only way you can get that kind of data and understand who's in front of you. And so Zhangyu Li has done this lovely job of going out to a bunch of primary care doctors, 65 of them in the Atlanta area, to understand what they think about AI. And currently you can see a lot of them use it for documentation and looking up guidelines. You'll notice the treatment still is not decided at all by AI. They very much follow insurance patterns, which is a sad reality of our care in the United States. But interestingly, you'll notice here that the attitudes tend to cluster around being very hopeful and engaged about AI, while also being skeptical about the idea that it might know something more than they do because they were trained to be a doctor. And this idea that they might not know enough about these clusters was a little bit problematic for a number of these clinicians. And so we heard a lot of qualitative things like, I've never heard of these subtypes, so I'm not comfortable. Or I dislike the idea of AI diagnosing for me or thinking for me. So this is definitely going to be an uptake battle as we think about the future. That said, there are probably potential efficiencies, and I'm going to pitch these to you. One, a bunch of questions that need answering, like, are these segments or subtypes and individualized approaches, are we going to use the same targets for each of them if we segment them? Are we going to use the same screening intervals? Are we going to need the same visit frequencies? Or could we get some benefits? You know, the mild age-related diabetes, do they need to be on 5 medications and come see us every 3 months? Or can they come once a year? Can we expand their screening to every 2 years, since they're not really going to develop complications at a very fast rate? Are there opportunities here to decongest our clinics, to de-implement care for people who don't need them? And what will this mean for our country-level targets and how we think about population health and global equity? To that end, Martin Rittersdrael and a few of us wrote what I think is a really nice futuristic thought about diabetes prevention and diabetes care, where we've made the argument that the future really is at a nexus between access, personalized care, implementation, and medical need. And that somewhere in here is the sweet spot, as long as we can really get away from these unrealistic, undesirable, unavailable, and unimportant aspects of diabetes care. So all that said, if we build it, will people come? And this is where I put it to you that there's a fourth area of a research agenda, which is how do you engage populations through behavioral economics, through precision policy. So if you think about this 2x2 that I showed you earlier of risk tolerant or risk averse versus present bias or people who are patient about the future, potentially the risk averse and the very focused on present bias might need a short-term incentive, a reward that they can get quickly. Potentially others, you can use different forms of this, but you can imagine that this is just 2 variables, an X and a Y. And when we add more to it, dare I say, behavioral phenotypes, then we will actually make a very complicated thing. And again, AI and others are going to need us to help. But there is an entirely amazing body of literature from Susan Mickey and others at University College of London, which once you figure out what patients are like and what their barriers are like, you can choose this group here, which is the intervention functions. Everything from coercion, which sounds appealing, to education, to training, and these are the ways that you get people engaged, and then you complement them with the gray group, which is policies that really drive us into the future. Some of this is being tested by Megha Shah and Joyce Ho, where they're using these very interactive AI tools to try to engage people in diabetes prevention in a pilot trial in Atlanta. So of course, all of you are thinking, this is great, Mo, but what about GLP-1s? Aren't they going to just drown everything out? And I understand the excitement and the panacea potential argument of this, and it's possibly true. In fact, John Dennis, whose data I showed you earlier, showed even in the pre-injectable GLP-RA classes that they already do better than every single one of these other oral classes. And when he, I think, has done a more recent analysis and done the once weekly semaglutide data, it literally doubles the A1C effect. The good news, or maybe not good news, is that I actually think variation still exists. And John Dennis and others have shown that it seems like GLP-1s are particularly beneficial in these groups on the right, females, those with very high A1Cs, those with residual beta cell function. And if that wasn't enough data, Hui Xiao in our group and Kiao-Chu Zhu have looked basically at genotypic variants and how GLP-1s work or not, showing essentially that if you had any one of these three variants, you had bigger effects if you used GLP-1s. And when they put that into a polygenic risk score, we had like a 70% relative risk reduction difference in MACE events in those people that had these genes and those who didn't. So I've said a lot. I gave you a Shakespearean title, and sorry to try to wrangle my way through all of those data, but I'd like to leave you with some thoughts, and here they are. The first is that I think our understanding of diabetes is much more sophisticated today than it was 18 years ago when I started in this world. And yes, we got it wrong for the first while, but I love this African proverb that says, to get lost is to learn along the way. And so I think even using averages, population impacts have been modest, but still hard to achieve. And so it's really going to be hard if we think about how to do this with precision diabetes. And so I leave you with this thought that, well, one size, does it fit all? I'll probably say, well, it'll at least fit some. There are some people for whom this works just well. You give them the guidance, they go do it, it works beautifully. It's really the ones that it doesn't work for, where the uptake is poor, or where they have a very severe phenotype. So for example, I think a lot of the money is going to be in the SID group, the severe insulin deficient group, and the SIRD group, who together make up 40% of people with diabetes. The other 60%, let's do what we can to help them lose weight or have a good quality of life. We might be over-treating a whole lot of people out there. So I believe the agenda for all of us is huge. And if I was a Bernie Sanders supporter, I would say huge. And I think some part of the work is in defining, preventing, and treating diabetes more precisely. I think we need to think about how to navigate implementation and supply side challenges of precision diabetes. And then the big one is, how do we optimize demand and policy for precision diabetes? And so as we think about this same stairway to heaven, if you will, we thought about it over the last 18 years as a linear path. And I think the reality is we probably can't wait for this to do it all linearly and wait for the previous data to do the next study. I think we need to do this in parallel. And a really great, smart mentor taught me once that the agenda is big enough for all of us. We don't need to compete. We just need to actually do it in parallel, learn from each other, and collaborate actively. You wouldn't be surprised to know that that collaborator and mentor is my good friend and mentor, Venkat Narayan, who is an ageless and amazing mentor, and thank you, Venkat, for everything you've done. When you eventually turn 70, I won't tell everybody when that is, I will become a good South Asian boy and call you uncle. And I know you're going to hate it. So thank you, everybody, for listening. I really appreciate it. Thank you to all our funders and to these amazing groups of people who've helped and worked with us along the way. Thanks again.
Please join me in giving Dr. Ali another round of applause for that fantastic presentation. Thank you all for attending this session. This concludes the session, and as we come to a close to the ADM meeting the next day, day and a half, I think Dr. Ali has left us with a lot of things that are aspirational as well as sobering, but a lot to think about after we leave the meeting. So thank you all for joining today.